advances in the NEC over the last 2 decades, and a lot has changed in the advanced world. So I thought it would be nice to bring in some new modalities, diagnostic modalities, prevention strategies, something new in pathogenesis, complications, etc. So we'll hopefully try to cover all those topics. So what is NEC? In literary word, NEC actually means death of a tissue. Necrotizing.
Can you do the full screen? If it is possible.
Yes, hang on a minute. I'm sharing it.
Just click the F5.
Click what? Sorry. Vikram, click what?
F5. F for flag.
F5. Okay, hang on a minute. F5. When I do F5, share. Let me see. Is this better?
Okay, continue. Thank you.
Nahi ho raha? It's not coming to?
I think abhi to screen bhi wo share it, yeah. Can you share it again?
Am I back? Can you see my presentation?
No, ma'am, it is not visible now. Before it was visible. Can you share again?
Hang on a minute, please. Hang on a minute. I'll see if I can get some help around here. Just a minute.
Yes, now it is visible and appropriate. Thank you.
Thank you, Vikram. All right. Okay, so we'll go back to the slide that we were discussing. So the literary word necrotizing means death or necrosis of a tissue. Entero, as we all know, is the small intestine. Colitis, because it involves the large intestine. Itis is a word that we know means inflammation. So it is the death or a necrosis of the tissue in the small or the large intestine, and secondary to inflammation. Let's talk about a bit of epidemiology. We know that this is an inflammatory intestinal disease. It affects around 5 to 7% of preterm babies globally. And it's basically the leading cause of morbidity, not mortality, but morbidity in preterm babies. So actually, it's a disease of prematurity. This is one of, just like intraventricular hemorrhage, NEC, and IVH are the 2 major morbidity that are associated with prematurity. The gestational age and the birth weight are very much correlated with the morbidity of NEC, and about 10% of preterm who weigh less than 1,500 grams, and approximately 30 to 50% who weigh less than 1,000 grams will develop NEC. So this is one of the huge risk factor itself for development of NEC. With respect to mortality, about 10 to 30% the preterm babies and those who have a very low birth weight, 1,500 grams, would also suffer from NEC, and the outcome is mortality in approximately 30% of patients weighing less than 1,500 grams. So in a very pathogenesis of NEC is elusive. There's a lot going on in bench science, animal models, in trying to derive what actually causes this intestinal injury, why there is a transmural involvement and leading to perforation, bacterial invasion, and translocation. So a lot of last 2 decades, people have been working around pathogenesis, and we're going to touch a bit of it with respect to what is happening new. Now, the incidence of proven NEC, when we say proven NEC, we don't mean NEC1, and I'll show you some data. Probably we are overdiagnosing NEC1. When we talk about NEC, Bell stage 2 and 3, it is very much known now that the incidence of NEC, Bell stage 2 and 3 depends upon the prematurity, that how premature that baby is and where is the baby located. That is a geographic location. This is a systematic review in Archive Disease of Childhood Fetal Neonatal Edition in 2018, and I would urge everyone to read it. It talks about the country of origin, and the incidence are correlated. So the highest incidence is 7 to 9% in Europe and USA, including Canada, Italy, while the lowest incidence is in Japan, only 2%. And even for extreme premature babies, the incidence is only 0.2%. So we know that extreme prematurity is a very big risk factor. But in Japan, it has been seen that only 0.2% of the extreme premature babies have an incidence of NEC. So, what does this say? So data derives interpretation and gives you new avenues for research. So this data tells us there's some potential role of environment, genetic, and diet. Remember, previously we used to talk that the premature gut is premature. There is it's a lazy gut. Emptying time is increased. There is an element of gastroesophageal reflux, and these babies they do not digest some amount of feed. So apart from all that we knew, this is an addition. That it is not only that, it is genetics actually. It is the diet of the mother, the diet, what we are giving to the baby, and the environment in particular, which may be actually causing a predisposition to NEC, and hence opens up new avenues for research. I'll give you some local scenario thought that was global and regional. This is a study done by one of our residents, Henna. She's now instructor faculty. And it was basically a descriptive study, but it did not look into the association. But what she found was that in the population that she recruited, there were 320 preterm babies. 7% were extremely preterm, while 41% were very preterm. And majority, as we all know globally, are moderate to late preterm babies. There wasn't a huge difference, but there were more males than females. And 94, if we talk about the birth weight, 94% of these babies who were recruited had a birth weight more than 1,000 grams, and only 6% had a weight of less than 1,000 grams. So she divided it into more than 1,000, less than 1,000. So NEC was observed in 29 babies, which makes a percentage of 9%. And I just gave you the data of USA, which was 9. But what is important, and what I want to highlight in terms of clinical implication, is that the stage 1 was 69%. So stage 1 is more clinical. Remember, it depends upon the environment that you work in, your experience, the attending, and many other factors. While stage 2 and 3 were 24% and 7%. So somewhat similar, but I think a bit of an overdiagnosis and hence we tend to really make our babies NPO very quickly, because we fear NEC is something that all attendings fear. So what are the risk factors? There are many risk factors in the literature. There have been consistent risk factors. When I say consistent risk factors, I mean there's significant, substantial, authentic data which shows that it is the type, it is definitely formula feed is related, as a risk factor. Intestinal dysbiosis, and we're going to talk about intestinal dysbiosis because we really do not speak about it during our rounds, during our clinical rounds, and we don't talk about what is dysbiosis, what is microbiota, because this is what today's age is talking about. They're talking about the microbiomes that are in our intestine, and a number of diseases have been related, that it is the intestinal microbiota which actually decides upon what diseases will follow in the intestine, and it also affects the neurodevelopment and various neurological diseases. Then the low birth weight and prematurity, we know these are consistent risk factors. There's enough data everywhere, regionally, globally, which says that these are definite risk factors for the development of NEC. Now, these are risk factors that you will see everywhere. There are maternal risk factors, and again, what type of maternal microbiota, and again, for the youngsters who are interested in research, there's a lot that can be done. The relationship between maternal microbiota and microbiomes and the neonates' intestinal microbiomes. And this is a huge area of research which is happening. And hopefully, I think in the next decade, we will be able to know what exactly can we do to prevent this microbiome from changing. In terms of chorioamnionitis, mode of delivery, use of cocaine, smoke, severe IUGR, high BMI in the mother, abruptio, preeclampsia, again related to the ischemia of the gut, intrahepatic cholestasis of pregnancy, and of course, antibiotic exposure, which would change the microbiome of the maternal gut. The main risk factors we just spoke about, so I'm going to skip them. But I think it's very important to talk about perinatal antibiotic exposure, because this is one practice that is very prevalent in the low and middle income countries, is the use of antibiotics. Prophylactic use of antibiotic has shown to improve the outcome in the mother, but it has also been associated with NEC in newborn babies. There are other risk factors that include congenital heart disease, and specifically the patent ductus arteriosus, exchange of blood transfusion, hypoxia, use of antibiotic for more than 5 days in the newborn. And I really like to talk about this right now, is we tend to give a lot of antibiotics in our units. Every preterm we think is vulnerable and will get some form of infection. So we need to somehow safeguard and give antibiotics. So what you're doing actually, your intent is absolutely correct. Your intent is to provide good care, safe care to the baby. But what you're actually doing is you're making that baby who's already has a main risk factor, the baby's preterm, and on top of that, you're adding another risk factor, which is the antibiotic use for more than 5 days. So a word of caution to all practicing neonatologists and a reinforcement that use antibiotic judiciously to ensure that you're not doing any harm to these babies. And of course, change in gut microbiomes, which one of the reasons of change in gut microbiomes is use of antibiotics, and hence its impact on the initiation of NEC. So when we talk about NEC, it's not only confined to gut. It is related to other organs in the body, including the brain. So genetic predisposition is one, and there's a lot of studies being done. Intestinal motility, mucosal physical barriers, when we give antacids in our units, and we all do. I think it's something that we have learned over the period of time, but I think it's time that we stopped using because we feel that there's a lot of reflux. We do not have the pH probes. So all is clinical basically. And if we see a baby with feeding intolerance who's having aspirates which are not discolored, or the babies had a history of abruptio in the mom, so we tend to think there's an element of gastritis, and we do give antacid, which can, of course, predispose the preterm baby to NEC. So a word of caution here also. Then we talked about microbiota, which is basically the microbiomes which are residing in our gut. And if there is an abnormal colonization with E. coli, Klebsiella, Enterobacter, Staphylococcus, then of course, these are abnormal microbial colonization. And of course, there are certain risk factors such as the TL4, interleukins, all these inflammatory toxins that are related, that are released once the inflammatory response has started. And we'll talk about this in the later slides. So I think I would really like to stress on dysbiosis because I feel it has a huge implication in our practices. And I say our practices because we all tend to incline towards the use of antibiotics and anti-acids. Now, dysbiosis is basically when the balance between the healthy organisms, microorganisms in our gut, that environment is disturbed. And so what happens is that instead of having a symbiotic relationship, there is more of a pathogenic relationship. So the balance between the healthy bugs and the unhealthy bugs, it gets disbalanced. And when there is a disbalance, then the condition called dysbiosis sets in. When dysbiosis sets in, then there is, of course, gut epithelium injury, and then there's a cascade of events that occurs. So if you look at the good bacteria, there's, and here about comes the theory of probiotics. So this is where the probiotics came into it. Again, there's a lot of literature on the use of probiotics to reduce the incidence of NEC, and we'll talk about it in the later slides. But these are the good bacteria, and these are the normal flora that exist in our gut. And there has to be a balance. If there is no balance, then dysbiosis sets in. So what scientists have seen and what lab investigations in rats have seen is that there is an increase of proteobacteria in the newborn, in the neonates stools, and in babies who have established NEC, stage 2 and stage 3, and they have a reduced quantity of Firmicutes and bacteroids. So Firmicutes and bacteroids are the healthy ones, and the proteobacteria is the unhealthy one. And when there is a disbalance, there's increased amount of proteobacteria, which then can start the cascade of the necrotizing enterocolitis. So how can we prevent dysbiosis is translation of this knowledge into clinical practice, is by not introducing undue use of antibiotics, number one. Number two, use of anti-acids. Number three, initiation of breastfeeding, express breast milk, early initiation of express breast milk, and ensuring that we are not starving our babies. These are all potential protective strategies to prevent the incidence of NEC. So you can see this is a schematic diagram of what really happens. So we've got a microbial dysbiosis, which you just discussed, which is antibiotic exposure and use of formula feed and reflux agent. And then, of course, there's always an immature intestinal barrier. And with it, we have an immature immune system. And there is whenever this cascade of NEC sets in, the toll-like receptors, which you can see are the TLR4, they're like rod-like, they get activated. And there is upregulation of the TL4 receptors, which releases further cytokines and chemokines. And these cytokines and chemokines then result in inflammation. If you look at the normal enterocytes and the lamina propria, it is nice blood vessels. The enterocytes have nice tight junctions. You have the villi up there, the mucus lining, and the commensal bacteria with the IgA. And as soon as this commensal bacteria dysbiosis occurs, then this commensal bacteria is disturbed. And what you get is less amount of healthy bacteria and more amount of unhealthy bacteria. And then that starts off the tissue injury. And these microbes then travel through the tight junctions, which are no more tight. They enter into the lamina propria, and then they, at the bottom, they affect the vascular angiogenesis and result in ischemia of the splanchnic circulation. What is happening at the ciliary level, at the villi level, is that the cytokines and chemokines, they're all pro-inflammatory, interleukins and many others. And what they will do is, of course, they will start the cascade of necrosis in the epithelial cells, and finally leading to perforation of the epithelial cells and what we know as pneumoperitoneum. So I think it's important to have this at the back of your mind when you're looking at a baby with NEC, that what is going on in these babies and how can we prevent it from happening. So the basic pathophysiology, and these are the recent advances in the pathogenesis of NEC. Nitric oxide plays a role. Toll-like receptors acts through PAMP. The microvasculature in this inflammation affects the microvasculature blood flow, resulting in intestinal ischemia. And of course, there's reduced activity of the stem cells. These intestine cells, they have the intestinal epithelial cells. They have a stem cell, which is a progenitor cells. It is called the intestinal stem cell. And they regenerate new cells every 4 to 6 days. But what happens is that when NEC sets in, the healing doesn't occur. There is no change in the intestinal epithelium because there's reduction of these intestinal stem cells in the crypts. So when the intestinal stem cells in the crypts are reduced, the healing process also does not occur. So there is a disbalance, and the physiology is now become a pathology. So these are all some of the risk factors that have been involved in the pathophysiology of the NEC, and nitric oxide is also one of them. That there is increased amount of nitric oxide release, and that leads to basically the increase in the cytokines being released, and then leads to a condition where it affects the intestinal inflammation, and sometimes the nitric oxide, they actually also affect the coagulation system and lead to a cascade of inflammation. Now, this was all about cellular level, but what is happening to the patient? What are the clinical features? Most of you know these clinical features, but basically because we tend to do residual gastric aspirates, it's a practice. I don't know if it is in non-unit, but the practice is still prevalent in AKU, and we are now trying to change the way our feeding protocols and our protocols too, because what happens is whenever you get a gastric residual, the resident on call, the faculty, and the nurses, they get very scared. And if the baby has 2 or 3 gastric residuals, then off comes the NPO sign. So I think this is an area which can be discussed. It's a huge area of intestinal motility and how feed should be given. But one of the things that happens is that you have gastric residuals, and so more than 33% of the feed that you have given, it should raise alarm that, okay, something is not right with the baby because the milk is still staying in the stomach, it's not going down. Of course, there are systemic signs. There's a fluctuating blood pressures, usually hypertensive. There's increased capillary refill. The baby may go into apnea, because then you know that if the baby goes into apnea, then you know. And if you've ruled out apnea prematurity, there, of course, you know, there's something sinister going on with the baby. Temperature instability, vomitings. If you look at the abdomen, it's usually distended, and the distension varies according to the stage at which the necrotizing enterocolitis is. If it is stage 2, 3, there is severe tenderness. There would be redness. There will be patchy area of blueness that you can appreciate in the photo that you can see. And of course, there'll be absent bowel sound, there'll be sluggish or absent bowel sounds, and lower right quadrant mass. If there is sign of, we might actually appreciate a localized area of tenderness, which is a sign that there may be perforation that has happened. This is basically just to revise our understanding of the modified Bell stage. We know that I believe it was 1978 when the Bell's criteria was introduced. And then, of course, there were modification in that criteria. Yes, it is 1978. There's modification in that criteria, and we now classify the NEC as stage 1, 2, 3, and of course, they're subdivided. Stage 1A, it's difficult to remember this, but what is important is stage 1A and 1B are the milder forms, while stage 2 and 3 are definitive NEC. So I think in stage 1A and 1B, it is important to ensure that you're not overdoing the diagnosis of pre-nec. We call the word pre-nec. It's something that I think we have developed from our practices. Just like presumed sepsis, we have a pre-nec, and you get a lot of pre-necs when you're doing calls. So it's important. Our clinical acumen is important, and the interpretation of these X-rays, because sometimes the radiologists the radiologists who may not be that efficient may actually label the presence of pus as pneumatosis, and this has happened multiple times in preterm babies. When we talk about 2 and 3, we are talking about definite moderate NEC. And of course, when we talk about 3, this is advanced, and with 3B, it's perforation and pneumoperitoneum. So we talked about clinical features. Sorry. Okay. Now, some of the triggers of feeding intolerance, as I mentioned, could be some prolonged duration of enteral feeding, an infection going on somewhere, a seeding of infection, or the transfusion of packed red cells. These are some of the clinical triggers of feed intolerance that you may come across in these preterm babies when you have started the enteral feed while the parenteral feed is still going on. So if you have a situation like this, the most important diagnosis is NEC, but SIP can be a cause. Now, a spontaneous intestinal perforation usually occurs in the early days. It's not something late. It is usually in the early part of the first few days of life. It is difficult to differentiate intestinal obstruction, but of course you'll have vomitings, bilious aspirates, infectious enteritis. These are all non-specific diagnoses, but the first thing that should come to your mind if you have a localized is a spontaneous intestinal perforation, if it is one of the first few days. Otherwise, NEC is something that one should evaluate. Now, as we all know, traditionally we have been using X-ray as basically our modality of treatment, and X-rays that we use are either are AP or they are supine or they are shoot through. And what we are looking at these X-rays is basically mucosal thickness. If you can follow some of these arrows, which shows that there's intramural gas. Here you can see gas in the portal tract. We'll show you some of the signs of perforation also. But basically, what would one look? One would look at the mucosal thickening, and if there are sentinel loops are fixed dilated loops that keep coming up with repeated X-rays that you're doing. Presence of gas in the intramural, in the wall of the gut, which is known as intramural gas, perforation, and then of course if the gas has tracked its way up from the peritoneum into the biliary tract. These are other pictures. You can see very clearly portal venous gas. If somebody asks you to look at a picture and always look just above the diaphragm on the right side, and you'll see the air tract. You can visualize, just like when we do RDS and we look at the air bronchogram. It is a similar. You have a white background of the liver, and just tracking within the liver are these small translucent black colored tracts, and these are basically portal venous gas. And then you have fixed dilated loops that you can see here, persistent, it's here as well as here, which are ominous sign that definitely there is something wrong with the baby and the baby is probably developing NEC. And this should be taken very seriously, and the management should start immediately. Pneumatosis intestinalis in the stomach wall can also occur. And if you can see in this particular case, it's not a very clear picture, but here you can, where my arrow is, you can see there is air around the stomach. And this is a typical football sign, which I'm sure most of you have seen sometime during your residency or while in practice. So the air has come out and it is all around the peritoneum. And it's called a football sign because it becomes like a football. It's a rounded structure where you can see airless intestine with black translucency air all around. Dilated loops, and then pneumatosis intestinalis, when you can see air in the bowel wall all over. Now, the other thing that I like to discuss, which we usually do not know, I'm not very sure if the practice is in the other neonatal units, is the use of bowel ultrasound, BUS. Now, the bowel ultrasound is something which is now coming up and people have started to use it. And what it does is basically it measures the mesenteric vessels flow, just like, you know, when we do the Dopplers in utero. You're looking at pulsatile index, you're looking at end diastolic volume. What are you seeing? You want to see the flow and the direction of the flow and the pressure of the flow. Doppler is simple, it's not something fancy. What you need to know is you need to understand the flow, the direction of the flow, and the intensity of the flow. So it has been, people are now looking towards BUS for evaluation of intra-abdominal pathologies, and there has been literature on its use for the diagnosis of NEC and early diagnosis of NEC, not only diagnosis of NEC, but actually the early diagnosis of NEC. And when I say early diagnosis of NEC, I mean that it picks up the gut ischemia, right? It picks up the flow in the mesenteric and in the celiac and the splanchnic vessels. And the appropriate use is in the early diagnosis of NEC. And sometimes, you know, it's very difficult to really find out, is this NEC or not? And sometimes the x-rays are equivocal. By equivocal is you're not sure, the x-ray is not really telling you, it seems like NEC, but it doesn't seem like NEC. And the benefit of doubt goes to the patient and the patient becomes NPO. So I would urge that if there are ultrasound modalities available in the units, we should start establishing the diagnosis of NEC on ultrasound. But for that, the challenges are how good the equipment is, how comfortable the pediatric sonologists are in interpreting the findings of NEC. And that has been the main challenge throughout the world in using BUS as a early diagnostic criteria or modality of NEC. And these challenges have been cited everywhere, but I think just like many other sonographic modalities that are now going on, point of care ultrasounds for various modalities, umbilical artery, umbilical vessels, pneumonia, RDS, this is another area which in future we will see that instead of having invasive x-rays with radiations, we probably in future would be seeing the use of more use of ultrasound and BUS as a modality for early diagnosis, early recognition. The idea is early diagnosis and early recognition. Just like IUGR, you want to pick up early, you want to bail the baby out because you know the flow is not that good. But of course, all of these have their caveats, and one has to take them into account when using BUS as a modality of diagnosis. It's a good modality when your abdomen is gasless, when you're looking at the complications of NEC, collection points, free air, peritonitis, especially when you're considering that the surgical intervention is needed and is required. So what you can see, I tried, because I think there's, I find this platform very interesting because it introduces you to some things which you may not be doing, not be learning during your residency or fellowship programs. So if you look at this, this is a Doppler ultrasound, and these are, pictures which are showing, these are actual pictures and the interpretation. So if you look at picture A, there is a normal flow and the bowel wall thickness is normal, right? There's the venous flow, the arterial flow, and a nice bowel wall. Now, what is happening? The changes of NEC, how are they interpreted? If you look at the B figure, what is happening is the wall thickness has increased. And at the same time, the hyperemia has increased. If you can see the red, they show the blood circulation, the splanchnic circulation, the mesenteric circulation, okay? Now let's move on to NEC getting worse. So what is happening now? The perfusion is now diminished, because remember when we talked about how there's a ischemia of the gut with dysbiosis and inflammation setting in. So what is happening? The bowel wall thickening is there, but now the ischemia has set in. Now when the ischemia is set in, there is going to be significant amount of thinning, right? And as a result, what would happen, the mucosa will start to slough out and the bowel wall will become thin. You can see from the thick bowel wall, it has now become thin because this bowel wall is now becoming necrotic and ischemic, and the mucosa had starts to fall off. And although the perfusion is almost the same, and finally, no perfusion and gangrene has set in. You know, when the surgeons, they tell you, okay, that the intestine was all gangrene. I had to just remove all the affected parts. So this is, if you look under a microscope, this is how it would look like. There is no blood flow. There is thinning of the mucosal wall. Perforation has taken place. So I think there is a role of BUS, and we probably need to delve into it further to improve our diagnostic early recognition of NEC to prevent this procession of pathology. We all know this laboratory evaluation. You all do it. I'll just mention some of the things which of late have been investigated. And remember, just like sepsis, NEC is one big animal, and we really don't know much about this animal at all. And so every now and then there are new modalities, and the idea is to pick up NEC early on so that the progress to perforation and peritonitis does not occur. If you look at the blood cultures, it is positive in less than 1/3 of the cases. CRPs are usually raised during stage 2 and stage 3. We do not get a high CRP in stage 1. And again, this could be one of the thesis or one of the research project that you can do is you can look retrospectively to all those babies who are called pre-nec or stage 1 and see the inflammatory markers such as procalcitonin, CRP, and then the blood cultures, and then compare them with those who had perforation or who had clinically Bell stage, and look at the difference. And then, that is data. That, okay, is it really useful to do these? If you get enough data, is it really useful to do these CRPs and procalcitonins and all this in stage 1 or pre-nec? So these are areas where there's a lot of work that needs to be done, and we can do it, and they don't cost a lot. You have the data with you, and those are areas that we could actually work upon. So there is, then recently we have serum and fecal calciprotein, pro-apolipoprotein, and desarginine. And these have been postulated as biomarkers for diagnosis with the sensitivity and specificity of 90 and 95%, but still these are not in practices. They don't, we are not doing it, and I'm not aware. I know some centers do fecal cal protected, but I'm not sure if this is been incorporated into the diagnostic modality for the evaluation of NEC, to the best of my knowledge. And would like to hear from others if if they can shed some lights on it. And of course, then the interleukin IgA, genotype, TNFA, interleukin 8, TLR, these have all been proposed as some markers for early detection of NEC, because we know that these are raised when NEC sets in. But I think these are late markers. And I think there is a lot of work to be done to know whether these are cost effective, whether they the sensitivity and specificity in terms of early detection and screening for NEC. Management, we all know what the management is, but I'll just go through it. You know, you need to rest the gut, we need to do orogastric decompression, we need to resuscitate for fluids because there is an hypoperfusion, but one has to be careful on not overdoing it or underdoing it. If the baby is in systemic DIC, coagulopathy, then one has to be sure that the heart is pumping nicely. Most of the time we are giving a lot of fluids and we do not know the functions of the heart. How is the heart pumping? What is the left ventricular output? So it's important when you're resuscitating babies, it's good to know what the condition of the circulatory system is. That can be easily done by invasive blood pressures, capillary refill time, and if you have a point of care targeted echocardiography available in your units, then one can put it and have a look at what the heart looks like, what it is pumping, diastolic and end diastolic volumes. TPN, of course, to provide early calories because you do need to, we tend to starve these babies. We do not give adequate amount of calories. And this is an area where we need to work upon that. These babies really need to receive decent amount of calories, at least 120 kilocalories, because there is catabolism going on. And for that catabolism, there is this expenditure of energy, and hence there is nothing left for the baby to grow. So it's important we don't starve the babies, they don't suffer from hypoglycemia, hyponatremia. The renal functions are good, that is, the fluids are enough, that there is good urine output, at least more than 1 ml per kg per hour. And to ensure that we are giving broad spectrum antibiotics, usually good to start with an aminoglycoside and a penicillin rather than going straight for third generation cephalosporin or other antibiotics, carbamazepines, such as meropenem that is being used. And we tend to start vancomycin very early. Staph is not one of the bugs that causes, and MRSA is usually not associated unless you have a line infection and you're very concerned. Then the use of vancomycin makes sense. Otherwise, sticking to broad spectrum antibiotics is good enough in most cases. The surgical management, of course, is something that we do. And the indication for surgical intervention is, of course, pneumoperitoneum, and that we know there is an intestinal perforation. We have two options. If the baby is extremely unstable, then there's a primary peritoneal drainage, which helps in evacuating the stool that is contaminating the peritoneum and the air that is distending and collapsing the bowel wall. And it gains some time. It's not permanent solution. It's an in-between condition where you are trying to salvage the baby. Of course, laparotomy is the solution, and either there's resection of the bowel gut or there is placement of an ileostomy and a distal mucus fistula. Laparotomy usually basically involves the effect. You probably all know this, but there are two things that are important. There's primary anastomosis and there's laparotomy with removal and an ileostomy creation. When babies who go under laparotomy and have resection, they would require a re-anastomosis of the dissected resected gut, and that usually takes place around 4 to 6 weeks ideally, but it varies from situation to situation. A contrast anemia is usually performed to ensure there is re-anastomosis, site is intact. There are no intestinal strictures because intestinal strictures are known to occur. However, if there is a short segment bowel that is resected, then one can actually do a primary anastomosis, meaning that the two healthy ends are anastomosed together, and there is no ileostomies, because ileostomy care is another challenge in our country, where the stoma site gets infected. Sometimes there is a stricture over there. Sometimes there is a secondary infection due to poor hygiene. At times it is primary anastomosis is better than doing a laparotomy and doing ileostomy, but it all again depends upon the severity of the condition and what the surgeon sees at the time of the laparotomy, and the decision is taken there, and then most of a prerogative of the surgeons. So as I said, this is a first surgery. You do an ileostomy, you take out the gut that is gangrenous, and then of course the second surgery, which is the re-anastomosis, you put the end-to-end baths. So what are the complications? We talked about it: perforation, peritonitis, septic shock, severe RDS. So these are the acute complications that occur in babies that have NEC, and you can see in this there is severe distension, there is gas under the diaphragm, there's gas in the intestinal intramural gas over here. Here you can see intramural gas. So this baby has is gone into stage 3. Now, if you look at the outcomes of NEC in systematic reviews that have been done, the overall mortality rate for Bell stage 2 and 3 is 23.5%. With surgical NEC, the mortality is high as 40%, and in extreme preterm babies is 51%. In another network study, Vermont, Oxford, which has multiple NICUs, they collect data from across many centers, and their study showed that the rates of severe growth failure, and when we say growth failure, it means less than third percentile weight for age, they were higher in infants who had NEC treated medically, that was 56%, or surgically, compared with those who did not have NEC. So the newborn babies who developed NEC and were saved had growth stunting. They were malnourished, and their growth trajectory was disturbed. And true for both the surgical corrected ones and the medically corrected ones, and compared to those babies who did not have NEC. So preterm without NEC, 36% rate of being underweight versus 56 and 66% if that preterm babies had developed neck. By 18 to 24 months follow-ups, the rates were similar in all 3 groups, but 1/3 of the quarter had a severe growth failure. So I think why I put this slide up, you must be wondering, is because we don't do long-term follow-ups, unfortunately. This is another area where the LMIC, especially Pakistan, is, and where centers like AKU, Indus, and now there's so many that are coming up. It's important that we have a network, and through that network we can do so much. And in that network we can have all these data, and then look at if you're saving these babies, what is happening to them when they're 2 years old, and what can be done. So if we know there is a burden, we would try to find out what can be done to prevent this from happening. Now, there are some adverse events which are chronic, and one of them is intestinal strictures. And we see so many babies who are otherwise well. You have treated the NEC, you've had a laparotomy done, you had an upper GI study done, all is well. But as soon as you start the baby on feeds, the baby does not tolerate. And we see a lot of it in our units. I'm not aware, probably because these are advanced NEC and the intestinal strictures are there. Sometimes there is a fistula, and the baby is actually having a vomit that contains fecal matter. And we've had 2 to 3 cases where the baby was well, was tolerating, but apparently there was a fistula, and resulting in baby throwing up literally poop in the vomit. So one should keep that in mind, that if a baby presents to you who's had laparotomy, who had NEC, or even who had not had laparotomy, who later presents to you with signs of intestinal obstruction, one needs to evaluate for strictures. Short bowel syndrome, you're all aware because the gut has been removed and there is a functioning of the gut, absorption of B12, folic acid, intrinsic factor, and that would lead to dumping phenomena. And of course, that would have an impact on the growth of the child. What is important is neurodevelopment impairment. Now there is enough evidence to suggest that these babies who develop NECs, especially stage 2 and 3, they have a very high chance of neurodevelopment impairment, and the pathogenesis that has been extrapolated or hypothesized has been again dysbiosis. So this dysbiosis is not only limited to the gut, but it is also affecting the brain cells and resulting in neurodevelopment impairment. Many of our young physicians are not aware of this fact that there is significant amount of involvement of brain in NEC, and that can lead to neurodevelopment. And again, the clinical implication will be what? That these babies would require some form of assessment, whether it is Bailey or any modified form of assessment, so that we can pick up this neurodevelopment problem earlier on and intervene with potential corrective or improving strategies. So what happens to those babies who survive? They are likely to be developmentally impaired versus those babies who do not have NEC. So you can see this is a twofold high risk in babies with NEC to develop neurodevelopmental impairment, some form of impairment. We know that NEC increases the risk of CP, cognitive disturbances, visual impairment, and those who are treated surgically, it is now known that they have poor outcomes in terms of neurodevelopment than those treated medically. Prevention. Prevention is better than cure. We all know this. And prevention, the other thing before we go into the prevention, I'd just like to give you some data on the strictures. This is very important. And this data comes from 4,260 patients who underwent a surgical procedure for diagnosis of NEC. 24% developed strictures. 13% had intestinal failure, which is known as malabsorption, in other words. 8% actually had recurrent NEC. Now, and there were 6% who had adhesion IDS. Why am I saying this? Because there's something called discharge teaching. If you know at the back of mind, my baby is getting better, I'm going to discharge this baby, alhamdulillah, all is well. But remember, this baby can develop stricture, this baby can develop a malabsorption, 13%. Chobis Fisa, 13%, recurrent NEC in 8%, and adhesion ILS in 6%. So there is going to be some discharge teaching where you're going to educate the parents of signs and symptoms. If they appear, these parents have to seek care in a place where preterm babies are managed so that these babies can be evaluated and offered treatment accordingly. Feeding exclusively breast milk, I don't think we can really emphasize more on breast milk. 2.8 times higher risk in formula feed, avoiding rapid increase in feed volume. So what has been seen is, this is a very blanket statement, avoiding rapid increase in feed. Every unit has learned with its time and has a protocol for standardized feeding protocols. And I think there is enough literature now which says if you're using one of the interventions that has reduced the burden of NEC in different units has been the use of standardized protocol. So instead of every faculty having his or her idea of increasing and stopping, one has to have standardized care. One has to have a consensus building exercise within the units. And for that, it would be wonderful to have the unit data, to look at the global data, to look at the evidence, how people have reduced the incidence of NEC in their units and learn from each other. And again, I'll come back to the same point. We do need in Pakistan a uniform, centralized data where these can come in, and from there we can actually evolve into developing standardized protocols for feeding and other preterm related conditions. Now, remember we talk about the balance and the disbalance, and the dysbiosis here comes in the role of probiotics and lactoferrin. So there has been a lot of literature on the use of probiotics and lactoferrin. There are studies which tell that there are certain types of probiotics which are helpful and healthy and should be used and can be used. At present, we are not using any form of probiotics in the units. However, we intend to carry out a study and see observe our experience. It's also important to know what the probiotic contains, what is the dose of that probiotic, how should it be given, when can it be given. So, I think there's more data that is needed in at least from our centers for the start of probiotics. Of course, many people are using it and they're getting good experience, good outcomes. Lactoferrin, I have a personal interest in lactoferrin. I've done 2 studies on lactoferrin. Lactoferrin is basically a proteoglycoprotein that is present in bovine milk. It is present in human milk, and it can be manufactured from cow's milk, goat milk, and it has the property of iron in it, and it serves as an antimicrobial, basically with antiviral, antibacterial activity. The study that we did was on extreme preterm babies and low birth babies, and we gave them lactoferrin, 100 milligrams and 300 milligrams in placebo. However, we did not find, it was a very small study on 300 neonates. It is going to be published soon, but we didn't find significant difference in the incidence of sepsis and the incidence of NEC, but there is a lot of literature, and I'll share some slides which I was given by Vikram, I think, and I've included that just so that people know what is going on. Lactoferrin. So lactoferrin, the use of lactoferrin is in maternal also, how to increase the iron content of the mother to improve the hemoglobin status during pregnancy and delivery. So lactoferrin, there are trials going on over there also. There are trials going on in seeing the impact of polio antibodies with giving lactoferrin, and seeing does the seroconversion, does it improve by giving lactoferrin. So there's a lot of work that is going on. And of course, needless to say, judicious use of antibiotics. Every newborn baby, every preterm baby does not need antibiotics. However, a preterm baby does need a neat and clean environment, and hence the role of infection control, hand washing, disinfecting, clean incubators, and so forth. TPN, ensuring that TPN are clean, our sinks are clean, our hands are clean. And I think we cannot limit emphasizing the use of infection control in the units. Okay. So I think I've spoken about this. There's some use of antenatal corticosteroids, probiotics, lactoferrin. There's also arginine supplementation, slow advancement of osmolality. There is a lot of literature on osmolality, and the osmolality should not be more than 450 milliosmoles per kg. Minimal enteral feeding. Again, there's a lot of different schools of thought. What is minimal enteral feeding? Continuous infusion versus intermittent infusion. So NEC is a huge topic, and it have been really difficult to cover all angles. I've just tried to sort of sensitize to some and speak on those which are very important. Feeding options, there are breast milk, human milk fortification, protein hydrolysate formulas, and probiotics. These are being used to reduce the incidence of NEC. Okay, discharge teaching. This is basically just a sample, but what we're talking about discharge is, remember, complications can occur. So it is important to teach the parents about complication. Number 2, it is extremely important to talk about breast milk. Most of the mothers go home and stop breastfeeding, and they switch to preterm formula. One should try one best. to ensure that they know the technique of expressing breast milk, they have adequate nutrition, they are not under any stress, and they understand and realize why breast milk is important for their baby and for themselves. What are the benefits to the mother for breastfeeding? If you can highlight them in terms of breast cancer, ovarian cancer, uterine cancer, postpartum depression, all of this will really help the mothers and give them any incentive to continue breastfeeding. I'm not going to talk about iron and vitamin D drops. Again, these are not, we do prescribe them, but again, there's not a huge amount of data. And these days, WHO is making guidelines in the use of vitamin D and iron, and they have found that as yet there's not enough good graded scientific data to encourage the use of vitamin D and iron. However, new guidelines are being made, and I think these are, again, research areas that hopefully in a decade or 5 years, we would know how much and what to give and when to give. And of course, regular follow-up to look at the growth of the baby, because we know these babies have problems with growth, and of course, NEC. This is a slide where it tells you rapid versus slow feeding. But again, this is data which is coming from 2014. There will be more trials being done, have been done on that. Usually in the units, the increment is 15 to 20 mL per kg per day. Most of the units do give trophic feeds, which are just 0.5 ml or 1 ml Q3 hourly, Q6 hourly, and then you move to slow increment of 15 to 20 ml per kg per day. However, Intergrowth and Interbio have come up with feeding for late preterms, and they have enough evidence to suggest that for late preterms or 32 plus, you can easily, and who are not intrauterine growth restricted, one can have rapid feeding as much as 30 to 40 ml per kg per day. As you can see over here, slow versus rapid did not show much differences, mortality or development of NEC. And also they looked at, when we do slow feed, it took longer time to regain birth weight. The references are given below. If you look at the risk of NEC, not a huge, 3.3 and 2.7%. So with slow feeding, longer time, but less risk of NEC. With rapid growth, less time to regain weight, but higher incidence of NEC. These topics are actually a huge topic within themselves. So I will not be going into the depths of all of these. Continuous versus intermittent bolus feeding. The All India Institute of Medical Sciences did the study, and they found not a huge difference between continuous feeding and intermittent feeding. My personal experience has been that in babies whom we struggle to increment feeds, continuous feeding somehow increases, continuous feeding helps us in increasing the increment in babies in which we fail to increase the amount of feed by intermittent feeding. That has to do with the physiology, the release of hormones, gastrins, and insulin, which actually helps the baby in reducing the feeding intolerance. However, they said the aims into, but this is old data. So, and they said that there is not a huge significant difference in the outcome. Again, an area of study for LMIC, for centers within Pakistan, where we can look at continuous versus intermittent feeding in our babies with the type of feeds and see what does the local data say, just like All India Institute of Medical Sciences have done for their babies. This is very important, and this is one of the most important slides because it is telling you, and I was speaking to some of my colleagues in USA, and the one thing that has really helped the units over there is standardized feeding regimes. And you can see this is a forest plot, and this is the line, the vertical line is the risk ratio. So if you have it on the right side, you see these red, these are the sample sizes, the boxes represent the sample sizes. If they fall on the right side, that means it is the intervention is helpful. It is, so you can see there is a significant reduction of NEC with the introduction of standardized feeding regime. So try to have a regime within the unit, follow that regime, which should not starve the babies. And if you follow it, then there are chances that the risk of NEC would be reduced, and there's enough data on this. This is a meta-analysis from 6 studies across the globe. Other things that have shown to reduce is the use of antenatal corticosteroids, and I think we all know this. Again, lactoferrin supplementation and NEC. As I told you, we didn't find anything in our study, but this is a study which this is a systematic review done in 2015, where they tell you that again forest plot right side, there's a huge standard deviation. The confidence interval is very high, but overall the diamond shape it's giving you that the use of lactoferrin actually favors the prevention or reduces the incidence of NEC. Similarly, with L-arginine, people have shown that use of L-arginine actually versus placebo does improve the outcome. So these are the references and the questions. I'm so sorry, I think I've taken beyond my time, but I'll stop here and thank you for listening. And I hope it has helped in understanding more about NEC and more about what can be done to prevent it. Thank you so much.
Thank you very much, madam. Participant, you can ask question. For asking question, you have to raise your hand, and then you can be allowed to unmute yourself and talk. So you can ask question. जब तक कोई हाथ रेस करे तब तक मैं एक दो सवाल पूछना चाह रहा था, मैडम.
जरूर पूछें. जी.
We are in routine practice. It is recommended, or we are performing that mere abdominal girth of a baby at least 6 to 8 hourly per shift. Even normal baby is passing stool and tolerating feed. And there is another practice of checking pre-feeding gastric residual.
Yes.
So is still valid, or we should continue, or we should look into it for the change in practice?
Thank you, Vikram. Those are two very relevant and very good questions, and I'm glad you brought them up. So I looked into the literature about abdominal girths, and there is no, in fact, this practice is not being done at all. And most of the centers have stopped using abdominal girth because it is not at all sensitive and neither specific. We all know the abdominal, the distension in the bowel can be because of many reasons. Right after feed, there's abdominal distension, there's a lazy gut, there is aerophagia during breastfeeding, and the presence of OG also increases the amount of air that goes into the gut. So abdominal girth measurement, I think, is something that we should not use. However, since this is a practice which is deeply ingrained in us and the nurses, it is important to produce some data on it. And if we can produce some data on it and see and show that this is a poor modality of recognizing NEC, then I think we will be able to get away with this practice. And same is true for gastric aspirates. Post-residual aspirates. Post-residual aspirates are not being done in many centers now. They used to do just like us, but they've stopped doing it because, again, of the factor of lazy gut. Again, the more you are, and when we do suctioning, we are actually imposing pressure on the stomach inside the gut wall, and that also can lead to trauma. So both of these things, I think, are areas of research for us, easy to do. Can be done by a multi-center study. We can have 4 hospitals recruit and look at what how do help us. Are they actually NECs, or are these just nothing and we are making pre-neck and stopping their feed, starving them, and then by starving them we are changing the intestinal flora, creating dysbiosis, and then these babies will move on to the actual milk. So I think both practices are something that we should seriously look into. And Vikram, the best way is to have data. Because once you have data, people cannot refute your data. And if you have data, then they will say, okay, there is enough evidence to suggest that these practices are of no good. They are resource intense. And I would go on to say that some physicians or some practices are such that they ask the mothers to actually monitor the abdominal girth at home. And that is absolute nonsense, because you are putting stress on the mother who's already stressed out in looking after a preterm baby. So this is my response to you. I don't have any slides to show you data on that, Vikram, but I could share it with you at a later stage. And maybe we could have a journal club on it or something, a combined journal club, and try to stop these practices.
Okay, ma'am. Thank you very much. Thank you again for your precious time. And just request if you can share your presentation with us. Few participants who are unable to join wants to review it.
Definitely, I will share it right after I finish this.
Thank you. Thank you very much. Allah
Thank
Hafiz.
you.
So we are ending this session today. Thank you.
Thank you, everyone. Thank you, Vikram, and all the participants. Allah Hafiz.
Allah Hafiz.